So let's go ahead and get started. Good afternoon, everyone, and welcome to today's virtual congressional briefing. My name is Tyler Smith. I'm the Senior Director of Government Relations at PAEA, and I'm grateful to have you all join us today. So I wanted to go ahead and begin this afternoon session with a few housekeeping points before we go ahead and get started. At the top of the screen, you have viewing options that allow you to exit full screen view and see side-by-side views if you'd prefer. If you have any questions at any point during the presentation, please feel free to go ahead and submit them in the designated Q&A box below, and they'll be answered at the end of the presentations today. With that, I'm pleased to hand it over to Dipu Patel, PAEA's president, for her opening remarks.
Good afternoon, everyone. Thank you, Tyler. My name is Dipu Patel, and I am the president of the PA Education Association and vice chair for innovation and professor at the University of Pittsburgh's Doctor of Medical Science program. I'm honored to welcome you all today to today's virtual congressional briefing entitled Strengthening Access to Care, the Role of Federal Health Workforce Investments. As we all know, access to healthcare starts with access to a healthcare provider. That's true whether you live in a rural town, a bustling city, or anywhere in between. And yet, too many Americans still face long wait times, limited provider options, or travel hours just to get to access the care that they need. These are not abstract challenges. They are the daily realities for millions of people. At the center of these challenges is one key issue: workforce. Today, we're here to highlight the powerful role that federal workforce investments play in addressing these gaps. Since their inception, programs administered under Title VII of the Public Health Service Act, like the Primary Care Training and Enhancements grants, the Area Health Education Centers, have had measurable impact in expanding access to care, particularly in underserved and rural communities. But here's the heart of the matter. We are in the middle of a growing healthcare workforce crisis. According to the Health Resources and Services Administration, more than 76 million Americans currently living in a healthcare professional shortage area. This is a staggering figure that indicates the scale of the challenge that policymakers and stakeholders are facing. The good news is that we have tools that work if we are willing to fund and scale them. When we fund Title VII health workforce programs, students from rural, underserved backgrounds enter health profession at higher rates and are more likely to return to serve their communities. When we expand clinical rotation opportunities, health professions programs can admit more students, thereby ultimately expanding access to care. During today's session, we have several excellent panelists who will provide their unique perspectives on these issues. I'm pleased to welcome Edward Williams, Program Director of the University of Arkansas for Medical Science PA Program and Chair of PAEA's Government Relations Steering Committee. Hannah Anderson, a lecturer at the University of Kentucky PA Program and member of the Government Relations Steering Committee. And Shelley Irving, an associate professor at the University of Kentucky's PA Program. In closing, thank you again for taking the time to join us today for our exploration of these issues. Through continued federal investments, we can ensure that patients in every community throughout the country have access to timely, high-quality care they deserve. And with that, I'll hand it over to Edward.
Thank you, Dipu. I want to thank you all for taking the time to hear our talk today, as was mentioned earlier, and I will quickly go through some perspectives about our program in Little Rock, Arkansas, here at UAMS, University of Arkansas for Medical Sciences. And as mentioned before, I am the program director and chair here. I'm also the chair of the Government Relations Steering Committee for PAEA. And so I just wanted to give you all some context of how the AHEX in our state has had a significant impact, not just on PAs and their education, but all medical learners here and future providers here at UAMS. All right, next slide. So let me just give you a quick overview of our program. We were first class started in 2013. We only take 40 students per cohort. We have up to 3 cohorts at a time. And we are accredited, continued currently with ARCPA. And we are housed in the College of Health Profession. And our overall objective is just to provide high quality clinical education across Arkansas. Okay. So we have what we call regional programs here. They used to be called AHECs a long time ago, and that name has changed. So you'll hear me mention regional programs throughout this, and that's talking about the same thing. It's basically just a rebranding for our university. So our regional programs here were formerly AHEC centers, as I mentioned before. They operate in the rural and underserved areas here in Arkansas, and areas there, they may not actually be physically in a rural area, but the patient population that they see typically are patients in rural and underserved areas. Some of them are situated directly in that as well. They do provide really important essential clinical environments for patients, and also really gives a good environment for our students to learn real time with real patients that have unique needs that they may not see other places. And one of the other bonuses about having our regional programs and our students attending them is they do provide free housing and meals to students, which is a financial benefit for them as well. Next slide. So our regional programs we have 8 of them, and you can see they're on the map here. They were founded in 1973. And they really were designed to help address the healthcare disparities here in Arkansas. And their main mission is to decentralize medical education and retain graduates in the state. And that is, since we are a state institution, that is one of the main things that we strive to do as well. Most of our students that enroll in our program, the majority of them are in-state students, and we work hard to make sure that they do stay in the state to provide this care to those areas that are most in need of them. And this regional programs used to only take in residents for internal medicine and family medicine training, but they opened it up many, many years ago before our program even started to include nursing, pharmacy, and allied health training there as well. So there's a multidisciplinary type of training environment that occurs at these regional programs as well. Next slide. So how does this impact our program overall? Well, almost half, 40%, of our students in each cohort have a rotation or more rotations at one of our regional programs across the state. And we've had, this will be a 10th cohort that just started just recently. And we could not maintain our rotations and our slots for students at an adequate level without the use of those regional programs. And again, you can see almost 50%, but almost half, 40% of them are experiencing those regional programs and the benefits that they offer there. And I mentioned earlier, they support family medicine and inpatient medicine rotations, and that's where our students get a lot of that hands-on experience in those disciplines. And it's always integrated with underserved communities. So again, our students can get that training and that understanding. We actually require that our students, all of our students before graduation, have a rotation in an area where there's an underserved population so that they can understand the unique needs that those populations have. Next slide. I mentioned these benefits earlier, but some of the benefits that the students really get out of this is a financial savings because they don't have to pay for housing and meals. They do get a really wide variety of patient populations that they just will not see consistently in a big hospital setting or in a clinic setting here in our urban area. And then we also have those immersive rural medicine experiences where students actually rotate in areas where it's very, very rural, and they get to understand and appreciate the uniqueness of those types of areas. Next slide. And then the community impact. These regional programs have a big impact on the local community financially as well as health related. They increase healthcare access, they strengthen local and healthcare infrastructures, and they help build relationships with the rural communities. And our students take part in that in many ways. And one of the ways here in this little picture is our students raise money every year to donate money to the food bank. And I think last year they donated $14,000 to the community food bank, which made a big difference. And having rotations in these regional areas and these AHECs can really help to make them understand why that's so important and how much community impact plays a role in what we do as healthcare providers. Next slide. Economic and workforce development. Like I mentioned at the beginning, we get graduates that graduate from our program and they stay in these areas and they work in these areas that they come from. We really work hard to recruit students from these rural and underserved areas in hopes that they do go back to work in those areas. And these regional programs give an excellent opportunity and chance for them to see and experience what it is that they're working for when they go back to these areas, or if they've never been to these areas before, especially. There's a boost economically from the healthcare and local spending, and then cost savings, because when we prevent diseases, we save money. And that is really what this is about when we talk about preventive and primary care settings, is identifying, treating, and managing through things that can help reduce morbidity and mortality in patient populations that they serve. Next slide. Success stories and outcomes. We really have high rural placement rates, like I mentioned earlier. We would not be able to function well as a program without that. Positive testimonials on readiness from our students that always come back and tell us how their experiences look when we have end of rotation seminars. All the students come back at the end of the clinical rotation. They get a chance to talk about their experiences, and almost inevitably there are regional programs that come up and talk about their experiences there in a unique patient population or a unique case that they dealt with at the regional program. And they also have excellent educators there as well. And they improve patient care outcomes. Our students, even though they're learning, they are still able to get in there, really get a good history and physical on the patient, and develop a treatment plan that they talk about with their supervising physician to get a good care, to get really good care for those patients and the attention that they may not always get if students weren't there to give them that time and that ear. Next slide. And speaking of success stories, I wanted to highlight, I thought about, really highlighting how our students individually have impacted and are impacted by regional programs. There were so many, but I wanted to pick one that we have a current student here, and her name is Briley. She has really been engaged with the regional program since she started in our program. She was recognized as an AHEC PA representative, which means she's almost like an ambassador for the regional program. She is an AHEC Scholar recipient. And she advocates passionately for rural health care careers, not just with other PA students, but with other students that she comes in contact with because of the interprofessional community that we have here on our campus. She gets an opportunity to meet and work with a lot of other students from other colleges here. And she originated from a rural farming community. And so she understands some of the complexities of what healthcare challenges they may face in those areas. And she definitely plans on going back. And all of this is just to inspire future PAs to serve in those rural areas. So we're really proud of Briley and how she's taken this extra effort outside of her learning and hours of studying to really put forward a diligent effort to not only advocate, but represent what PAs can do in these areas. Next slide. So our challenges and what we need for congressional support. There's an increased demand for these regional programs, but we have limited site and funding. So the more that we can open access to our students and to our learners, the more we can get them ingrained into those challenges and needs, and hopefully work in those areas as well. Sustained increased federal funding is really one of the main reasons that we're having this conversation today, to give you the context and the challenges, as well as positive impact on healthcare and outcome qualities, especially in the areas here in Arkansas, where most of our state is considered a rural and medically underserved areas. And I think the last slide coming up here. Summary and call to action. We're really wanted to emphasize the importance of UAMS regional programs under Title VII. If we did not have that, I cannot overemphasize how challenging it would be. And if we had a decrease in the availability of our students to rotate there, it would have a significant impact long-term, not just for our program, but for healthcare here. Benefits to students, community, and healthcare really highlighted that. And I think all of that comes to summarize really that we need support for increased funding for AHECs and our AHECs or regional programs here in the state. And this is something that I know that you all can take back and make an impact and shine that same light on this need. And with that, I really want to thank you for your time and for your attention. And I think now I will pass it along to Hannah and Shelley.
All right, well, thank you. And thank you for the opportunity to speak today. I'm Shelley Irving, Associate Professor in the Department of Physician Assistant Studies in the College of Health Sciences at the University of Kentucky. I also serve as Principal Investigator for the Primary Care Training and Enhancement Physician Assistant Rural Training in Behavioral Health, or PCTE PARB HRSA Grant Award. This was awarded to our program this year. We're one of 13 PA programs across the country receiving funding through this HRSA grant program. And so, shout out to anyone from any of the other programs on the call. It's happy to be on this journey with you all. I'm going to take the next few moments to share how this program is helping us here at the University of Kentucky to increase access to high quality care, much needed care, and a provider workforce that we need across our Kentucky regions. I have one disclaimer before we get started, and that is that this project is supported by the Health Sources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $2.2 million with 0% financed with non-governmental sources. The content are those of the authors and not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. Next slide, please. So at the University of Kentucky, we're very mission driven with a focus on advancing healthcare in underserved and rural communities across Kentucky. Our program is celebrating its 50th year this year, and we have 2 campus locations, one in Lexington, Kentucky, which is an urban area, and then a rural satellite campus at Morehead State University, which is in the heart of Eastern Kentucky's Appalachian region. Our rural campus, for which I serve as site director as well, was established 30 years ago. We take 16 students per cohort at our rural campus and 40 at our urban campus. So we have a total of 56 students per cohort across both campuses. We have a 29-month program. It's a 95 credit hour professional master's degree that is conferred upon completion of the program. Over the past 5 years, 74% of our matriculated students have identified as rural. 40% of our total clinical rotation placements occur in HRSA designated rural areas or rural sites. And then our department was previously awarded a Substance Abuse and Mental Health Services Administration, or SAMHSA, grant in 2021, which enabled us to ensure that 100% of our graduates are medications for opioid use disorder, or MOUD, waiver trained by the time they graduate. That grant ended this year, and so the PCTEPARB grant, which we currently have, is enabling us to continue that training to ensure that we provide a workforce prepared to care for patients with substance use disorders. Next slide, please. We've titled our program A Healthier Appalachia through PA Training in Primary Care and Behavioral Health. Much of Kentucky is part of the Appalachian area, which is HRSA designated as medically underserved in primary care and behavioral health. And we all know that Appalachia, and particularly Central Appalachia, lags behind in health outcomes. We also know that health is connected to workforce and the economy. When we review data from the Appalachian Regional Commission and HRSA, we find that mortality rates are higher across Appalachia for preventable illnesses, things like heart disease or chronic obstructive pulmonary disease, as well as for overdose deaths. We have higher rates of depression and suicide as compared to the national average. Kentucky also has one of the highest prevalence rates in the nation for adverse childhood events. The number of primary care physicians per 100,000 people is 33% lower in Central Appalachian Kentucky than the national average. 83% of our Kentucky counties contain HRSA designated medically underserved areas. 98% of our Kentucky's Appalachian counties contain HRSA designated medically underserved areas. 94% of our counties are HRSA designated health profession shortage areas in primary care, and 95% of our counties are HRSA designated health profession shortage areas in mental health. 90% have that health profession shortage areas designation for both primary care and mental health. So we have a workforce shortage of providers trained to provide primary, preventative, and mental health care in these communities. The goal of the PCTE PARB grant is to address the shortage through increasing the number of PAs trained to work in these areas. Next slide, please. The PCTE PARB grant is a 5-year, $2.2 million award that began July 1st, 2024 and continues through June 30th, 2029. It's a large and ambitious project for our department. Next slide, please. This is our department, and essentially everybody is playing some sort of role through the administration of this project. Next slide. So we've organized ourselves into teams, which is helping us to make sure that we administrate the grant appropriately. And so whether it's being involved in administrative support or leading out on particular objectives for the grant or being part of that assessment and evaluation piece, we have created a structure, excuse me, that will help us lead this grant out hopefully to success. Next slide, please. So what we've been charged with is, again, increasing the number of PAs trained to deliver behavioral health services in rural areas, including prevention, identification, diagnostic, treatment, and referral services. And so we have 3 objectives that will help us meet this goal. The first one is by ensuring that strategic partnerships are in place to be successful. The second is enhancing our didactic and clinical curriculum to address behavioral health and substance use disorder within the context of rural primary care. And then thirdly, by developing and implementing an immersive experiential learning opportunity for select students in rural integrated behavioral health. Next slide, please. We have long-term strategic partnerships with area health education centers, or AHECs, who provide support to our students when they are participating in rural clinical rotations within their regions. We've strengthened the relationship with 3 of our AHEC regions who serve our Appalachian counties, and that would be the Northeast, the Southeast, and the Southern regions on the map there. And they are helping us to identify integrated behavioral health in primary care clinics for the experiential learning component of the grant. They also support our students who are on rotation in any of these rural areas so that they can be successful, have housing, have gas stipends, have the things that they need to go into those areas for 1 month to 3 months, however long, and have those experiences. They're also very supportive of this grant work because it aligns with their own missions, which is to support access to local high quality health care for their communities. Next slide, please. And so where are we on meeting, our program mission? Over the past 7 years, out of nearly 380 graduates, 37% of all and 62% from our rural campus work in a health professional shortage area. 25% of all and 37 from our rural campus work in a medically underserved area or population. 32% of all and 49% from our rural campus work in a rural area. When we look at just the previous 2 graduating cohorts, we see that over half of them are working in a medically underserved community. Not only do we think we're doing a pretty good job meeting our mission, but we've recently seen an increasing trend in our graduates taking their first PA jobs in these underserved communities. So now that we're 10 months into this PCTE PARB grant, where are we on meeting the goals of that grant? And so this grant opportunity is really supporting our continued efforts toward increasing access to high quality care in medically underserved regions. So what we've done so far is establish an advisory committee with important stakeholders to help advise the project as we've developed it and are implementing the components of it. We've developed, implemented, and completed the pilot of the 3-month Rural Integrated Behavioral Health Clinical Rotation Experience. That was a huge success, and that portion of the program is rapidly expanding, providing more opportunities for students to have these experiences. We've developed interdisciplinary continuing education opportunities, one of those being the first annual Integrated Behavioral Health Conference, which we have scheduled for May 30th, so in just a few weeks. And we've developed enhanced curriculum, which includes, but is not limited to, rural integrated behavioral health interprofessional educational experiences, standardized patient encounters, and simulations to, again, help ensure that our students are prepared to go work in these areas. And so we're really thankful and grateful for this opportunity to have this grant and to be able to engage with our stakeholders, strengthen our relationships, and to promote this much needed workforce that we have. We have this great gap here in our Appalachian region, and so thank you for your time today. And with that, I'll turn it back over to Tyler.
All right. Well, thank you so much, Shelley. So, we wanted to wrap up our discussion today by zooming out a bit and talking about the broad scope of federal investments that Congress makes in the national health workforce, as well as PAEA's recommendations as Congress begins the fiscal year 2026 appropriations process. And just to build on the disclaimer that Shelley provided, so I just wanted to note at the top, these recommendations are just the view of PAEA and not the view necessarily of the grantees on the call today. So with that, we can go ahead and get started. So I wanted to begin just by defining our terms. So we've heard the terms Title VII and Title VIII used a lot, but what exactly does that mean? So the range of health workforce programs that have been discussed today, from area health education centers to primary care training and enhancement grants and other opportunities, all fall under an umbrella known as Title VII. So all of HRSA's health workforce programs are authorized under Title VII of the Public Health Service Act, and Title VIII of the Public Health Service Act authorizes programs that invest in the nursing workforce. While just a few of these programs have been highlighted during the course of the discussion today, it is important to note that Title VII actually authorizes a pretty broad array of programs that support a health professional over the course of their lives and careers, from the K-16 level, K through 16 level, through graduation and completion of their programs and the point at which they enter the workforce. In terms of PAEA's key priorities, in addition to both AHECs and primary care training and enhancement grants, we're also supportive of a number of other programs under Title VII, specifically scholarships for disadvantaged students, the Health Careers Opportunity Program, and others like faculty loan repayment and programs that invest in the development of the substance use disorder workforce. So throughout the appropriations process, PAEA has long been a proud partner with other stakeholders as a member of the Health Professions and Nursing Education Coalition, which represents over 90 health professions organizations across the country. For FY26, HIPNIC is requesting a combined funding level of $1.51 billion for both Title VII and Title VIII. This funding level, which is a significant increase from the $886 million provided by Congress in FY25, really reflects both the scale of the national health workforce crisis we're seeing, particularly in rural communities across the country, as well as years of chronic underfunding of these efforts. So diving a bit deeper into the specific recommendations that PAEA has made. So as Edward discussed, the goal of the Area Health Education Centers program is really to both address clinical training site shortages, as well as retain health professions graduates in the communities where they're needed most after they complete their programs. So in FY25, the AHEC program was funded at $47 million, and PAEA's recommendation is that this be increased to $86 million in fiscal year 2026. Building upon the work of AHECs, PAEA is also supportive of the goal of the Primary Care Training and Enhancement Grants program, which provides both PA programs as well as medical schools and physician residencies with the resources necessary to expand access to clinical training opportunities and really facilitate a strong pipeline of graduates into primary care specialties where we tend to see the most significant shortages. Currently, this program is funded at $50 million annually, which allows about 30 PA programs across the country to be funded at this level. To really build the capacity of the program as well as the work of grantees across the country, PAEA is recommending a funding increase to $98 million as we continue to see primary care workforce shortages in communities across the country. As I mentioned, beyond the programs that have been specifically highlighted during our session today, PAEA has also published appropriations recommendations for a number of other Title VII workforce programs. So as I mentioned, for the programs, they're really focused on expanding access to the PA profession for students, like the Health Careers Opportunity Program, which supports outreach and enrichment efforts at the K through 16 level. PAEA is supporting an increase in annual funding from 16 million to 30 million. For students that are already matriculated into a health professions program under the Scholarships for Disadvantaged Students program, SDS is really intended to provide them with the financial resources necessary to complete their program and then enter the workforce. And so for that reason, PAEA is recommending an increase from 55 million to 103 million in FY26. Beyond both HCOP and scholarships for disadvantaged students during the FY26 appropriations process, PAEA has also advocated for increased resources to facilitate the behavioral health workforce that's really needed to sufficiently address the national substance use disorder crisis that we're facing. Specifically, towards this goal, PAEA supports the Mental and SED Workforce Training Demonstration Program that's administered through HRSA that really provide the clinical experiences necessary to direct more PA graduates to the field of behavioral health. So really to build upon the work that the program has pursued up until this point, we are recommending a $15 million funding increase from 35 million to 50 million annually. So, in summary, with 76 million Americans currently living in primary care health professional shortage areas, PAEA's advocacy has really been focused on addressing years of insufficient investment in health workforce development by providing bold funding increases for both Title VII and Title VIII health workforce programs. By making these investments, Congress can ensure that all patients have access to the timely, high-quality care that patients deserve. So with that, we're going to transition to the Q&A portion of the presentation. So I'm going to stop sharing. And just a reminder, if you have questions, feel free to go ahead and enter them in the Q&A box at the bottom of your screen. And while we wait for some questions to get in, we'll just kick it off with a few discussion prompts. So one thing that was talked about during the course of the session today was really the challenges that programs are facing in terms of clinical education as we work to make sure that we're producing enough graduates to meet workforce demand. And so the first thing that I just wanted to open it up to the panel with, what are the greatest challenges you're facing in training PA students to meet the healthcare needs of communities across the country, whether that be clinical site shortages or anything else that you might want to elaborate on? So if anyone wants to kick it off.
I'm happy to get the conversation started. So here in Kentucky, I think our biggest challenge is actually legislative because we we have a culture here of not promoting PA practice at the top level of PA's ability to practice, and so that sometimes hinders not so much the educational piece, but then that workforce piece, right? Getting our graduates into the workforce and then retaining them in the workforce. That can be very difficult once they get out into practice and realize they can cross the border. They'll stay in Appalachia, but they can cross the border into another state and their practice life looks very different. And so that's a challenge that we've been fighting for quite some time here.
I can add something just briefly. I know you mentioned, Tyler, clinical rotations, and that has been a persistent challenge for us is finding enough adequate rotations for our students, especially when we're dealing with competition from other medical schools as well as other PA programs that may be paying. Our program still does not pay on a regular basis for clinical rotations. I fear that's going to change soon. And the reason that we've really been resistant to it is the cost to students, because that cost gets pushed off to them. And that's going to increase tuition and decrease the ability for many students to be able to even afford a PA training and education. And that goes to grants and other things as well. But that continues to be a barrier, is having enough adequate rotation sites. And again, I have to go back to that's why our AHEX regional programs have been such an asset for our college, at least because they're a part of our university assets, but that's not the case for every school.
Yeah, I think that point really illustrates the importance of funding opportunities like PCT, PARB that really open the door to preceptor compensation for the first time in a really long time. I think that's been one challenge with some of the HRSA programs is not making resources available to really expand the preceptor pool. And so I think when HRSA moved in that direction, it definitely made a big difference for grantees. So. All right. So moving on to the next question, and some of this was also discussed during the course of the presentations, but just interested if you all could share your perspectives on really the most important factors that help retain PA graduates in underserved communities after graduation. I think we all know that there are lots of competing dynamics, whether that's compensation, whether that's family issues. So what have you seen really be effective in getting folks retained in the communities where they're needed most?
I think for us, retention really comes back to that exposure. And so by working with our AHEC partners and our other strategic partners in these underserved areas to get our students those touches throughout the curriculum, especially the clinical curriculum where they're embedded and immersed in those clinics, that really is often what leads to those job offers and then those first job placements. And so for us, that's really been a game changer because I can't give you a percentage off the top of my head, but I can tell you it's a significant percentage of our graduates. Their first job comes from a place where they experienced a clinical rotation. And so without that opportunity, without the support for those opportunities, I don't think our statistics would look as good as they did when I shared them.
Yeah, and we definitely see that borne out in the national data as well. The PAEA collects is clinical experiences that programs facilitate for students across the country are really one of the most major factors in terms of their first job placements. So, to the extent that federal policy can help to facilitate those placements in the communities where they're needed most, that's really a win-win for the programs and then ultimately where they end up employed.
I'll just add really quick. I know that I agree with Shelley. That exposure has been the most impactful and important as far as outcomes with getting students in those areas working. I think another program that's been really helpful is the National Health Service Corps. NHSC or their scholarships or their student payback helps. We have several students in every cohort that take advantage of that opportunity, either before they matriculate into our program or after they graduate. And that gets them back into those areas that are really underserved and gives them that incentive of a financial compensation in one way. And again, the students that we've had to take advantage of that really benefited both financially as well as experiential in being able to get to those areas and work there.
Yeah, I think that's a great point. So there's a stat that I saw that really blew my mind that due to some of the funding increases that Congress made available a few years ago, the number of PA students that received scholarships under the National Service Corps went up by about 600% since 2017. So I think that's a great example about really the impact of some of these federal workforce investments, especially with a program like the National Service Corps that has a retention rate of about 85% after they complete their service commitment. So yeah, that's a great point. Thanks for raising that. All right, moving on to the next question. So, in terms of thinking like long term, I'm sure you're doing a lot of thinking about this with your award, Shelley. What long term tracking or evaluation methods are you using to really assess the sustained impact of your HRSA grants after students graduate? I think it's one thing to make funding available on the front end, but I think Congress really has an interest in making sure that it's durable to the extent possible in getting folks in rural and underserved communities and also in primary care. So, how are you thinking about kind of like long-term outcomes tracking?
Yeah, for sure. Thanks for the question. And so we've taken a lot of time over the past 10 months to really, in working with our advisory committee, to really try to design, the curricular enhancements and the 3-month clinical experience in ways that are sustainable that will live even beyond the 5-year grant period. And so having involving our strategic partners in some of those conversations and addressing potential barriers and potential challenges up front. And as they go, that advisory committee meets every month. And so we're able to in real time sort of troubleshoot any challenges that we come across has really been helpful. And then structured the way we are, we have an entire evaluation team that's working right now. They've got some surveys out. They're working on collecting data not only as we go, but then we use the MPI numbers that our students will apply for before they graduate to then follow them. Right, they're getting that first job in that underserved area. How long are they staying there? Right, what is that long-term economic impact to that community, as well as the health impact to that clinic and to that region where they're practicing their catchment area. And so we've really tried to be thoughtful as we've designed it, and thinking beyond just the 5-year period that we're on the hook for, if you will, to HRSA.
Absolutely. And I think you're engaging in a practice that's become more and more common with programs across the country, really like having students get an MPI number early in their training so that you can really track it, and not even outside of like a HRSA funded context, just kind of see where your folks are ending up. So, Edward, I know you don't have a funded project right now, but if you want to talk about like alumni tracking or anything that you're all thinking about in this space, feel free.
Yeah, MPIs have been really helpful for grants that we have applied for in the past, but also just it's incredible how often we get questions about, well, how many of your graduates are staying in state, and how many of your graduates are working in these rural areas versus in other places, and being able to get those MPI numbers makes that data and collecting that data a lot more efficient and effective than just trying to scrub through all of the different things, including when students change their names. So it's helpful in many ways because that follows those students, and we can get some longitudinal data that really supports what we've done and what the graduate has done.
All right, so looks like a question just came in. Do we have any idea of continued HRSA funding with the new administration interested in scholarships for disadvantaged students that is scheduled for July 1st, 2025? Yeah, so just to give a sense, so the current cohort of scholarships for disadvantaged students grantees is scheduled to expire this year. So assuming that Congress continues to provide funding for the program, we're anticipating another competition to be released within the next few months or so. All right. Going to the point about PA programs access to HRSA grants. So this has been kind of like a long-standing issue in terms of capacity. So we've seen challenges with PA programs perhaps not necessarily having the grant writing capacity built in that other institutions like medical schools and residencies have. So have your programs experienced any challenges in accessing HRSA opportunities? And what advice would you give to other programs that are interested in pursuing grants?
We're very fortunate at the University of Kentucky to have a lot of support. And we have Office of Special Projects, and we have all these different departments and individuals that come along beside our department as we apply for and then roll out grant projects. And so I do very much empathize with programs and other areas that don't have that kind of support. And then you can see just for our department, it's an all hands on deck. Everybody is involved in some way to make these things successful. And if you don't have that buy-in and that support within your department, there's just, I mean, I don't know how anybody could successfully launch any sort of a grant, either writing a grant or launching an award that they've received. And so we're fortunate in that way. But that would be my advice to anybody is look for those folks, get that buy-in, get the whole team on board, and try to find your allies across your institution that will help you do that, or even strategic partners, even outside your institution, if you need to help make something like that successful.
And then Edward, I don't know if you had anything you want to add in on that if your program is thinking about applying for grants.
Shelley has been killing it. All I can do is just add a little, side note to her comments. She's been doing fantastic. I really don't have much more to contribute to that. I do know that with our institution, HRSA grants are not as popular or as well known as NIH and other types of grants, and so there is a learning curve sometimes with institutions that have support. And I think it's important for any program that wants to get involved with that to know what resources they have available, but even more so how they can help them on a technical level in getting these grants done outside of what they typically do for things like NIH grants.
All right, just a couple of final questions on my end. So we've seen a lot of evolving pressures on students over the course of the years, whether that be increased cost of higher education, different push and pull factors in terms of where they can practice, where they're interested in practicing, where the workforce needs are. So can you speak to kind of like how your experience working with students during your time in education has changed, and kind of any emerging pressures that you're seeing them experience as they're making their choice about their future careers?
Okay, I can jump in on this one first. And one of the challenges that we have seen, and it's rather unique, but to Arkansas, but it may be a situation that's relevant in other states as well, is early on, our population of PAs here in Arkansas was pretty small. I got here in 2014. There were about 300 licensed PAs in Arkansas. Now we're close to 800 licensed PAs. And in that time, and we only have two PA programs here in Arkansas. And in that time, a lot of our graduates would be going out of state for jobs. And so that would kind of defeat the purpose of having a public school system that's paid for by tax dollars. And then our graduates go to another state. And that part of that was because other states have better scope of practice laws that allow PAs to do more and to do better and have more job availability. We've really made an effort legislatively with our state organization to get many bills passed. Over the past 3 legislative cycles, we've gotten 5 different bills passed to help improve scope of practice here in Arkansas. And so we're hopeful that in the short term and the long term, we'll see a difference in that migration away from the state for people who are in-state students, and that they stay here because their scope of practice laws will allow for more conducive and more better hiring practices for PAs here.
I think the only thing I would add here, we've seen a change or a trend in our students from a more non-traditional second career, students who have a lot of experience in the workforce, a lot more life experience, to younger students who maybe haven't had a previous healthcare career or have had a lot of life experience. And so that comes with some great benefits, the youth, the enthusiasm, they're ready to take on the world. And it's, the energy is phenomenal in the classroom. But it also brings some considerations as we think about how we teach them and train them and prepare them to go, out into a workforce. When we think about things like professional identity development and things like that, we spend more time, more conversation around that, I think, than we used to make sure that they're truly prepared when they do launch into those first PA careers.
All right, so we just had another question come in, and I think you might have some particularly good insights on this, Shelley. So it says, being a part of a developing program with a mission for rural and underserved populations in Arizona, but new to academia, how would you summarize the step-by-step process for finding and applying for these grants? So well, I'll give you a second to think. Just a couple of things to be aware of from the PAEA standpoint. So anytime a new HRSA grant opportunity, particularly PCT, comes along, we put that on our networker and on our website just so folks are aware of the opportunity. In terms of grant rating resources, we also have a number of things that I would point you to on the Digital Learning Hub in terms of the experience of prior grantees. So if you haven't checked that out yet, definitely encourage you to take a look there for some resources, and to read our networker every week that comes out to be aware of when these opportunities pop up. So yeah, Shelley, I don't know if you want to talk about your experience in the space.
Yeah, sure. So, yeah, email me. Feel free to reach out to me for sure. Yeah, I would say probably the biggest thing is to be on the look for those NOFOs, those notice of funding opportunities from HRSA or whoever the grantor might be. Find out early. They put out a lot of information in that NOFO. They'll have webinars where they'll give you more information. Reach out to other programs or other people who've had similar grants. That's what I did. I've had other grants, but this is my first HRSA grant. And so I was able to reach out to colleagues who had had a similar grant previously for a different health profession, and was able to get some information that helped me. There's a lot of alphabet soup, particularly with the HRSA grants, and so that was probably my steepest learning curve, was just learning all the verbiage and the acronyms and things like that. So my short version is find out early. Make sure that you're attending those webinars. Try to connect, network, collaborate with others who maybe have had this opportunity before or been through something similar, and then make sure that you're reaching out when you need help early and often. And I will say, from my perspective, the team at HRSA that we're working with, they're great. They're very quick and easy to get information back from. They've been very helpful, and so that's another resource you want to lean into as well.
All right, so I think we can wrap up with this last question. So, based upon all the experiences that you've had, either with your funded grants or with leveraging other resources like area health education centers, as Congress is kind of kicking off the budget and appropriations process this year, what is one takeaway that you would want to leave staff with as they're thinking about policy solutions to our workforce challenges?
I think one takeaway from all of this is if we don't invest in the future of healthcare providers, we're not going to have quality healthcare in our country. And I know it sounds really basic and common sense, but it requires an investment. It requires planting those seeds of financial assistance in order to continue doing what we have been doing for so long when it comes to improving healthcare, but also an effort to make it better than what it is today. And the only way that we can improve upon the situation is to continue to support that product or that grant or that funding so that we can make better healthcare decisions for our students and when they graduate, and they can make that for their patients when they're sitting in the room with them one-on-one.
Yeah, I think you said it really well, that investment of resources, whatever that may be, but it's got to be intentional, right? And we have to really focus on those areas that we know are needed. And for me, I'm always trying to think about what are the consequences, what are the unintended consequences of something. And so I think raising awareness to for the need, highlighting those areas where we can be really intentional, I think is important as there are plans being drafted and conversations happening around investment of resources.
Anything you wanted to add in, Deepu or Hannah, before we wrap it up?
I'll just say more anecdotally that something so inspiring is seeing our students that have, when they come into the program, no interest in rural health, and by the time they graduate, they are on a fast track to get the most underserved job they possibly can. And I think so much of that passion comes out of the sort of the opportunities that are provided for them to step out into that space. But that does require support and infrastructure. And it's been so cool to be at UK and see that process happen. But it's like Shelley said, I'm so thankful that we have the support that we have to be able to provide those experiences and foster those sort of eye-opening exposures for students, because we need purpose-driven providers in rural spaces, and we have them, and we have people who have, all of the skills and capabilities and passions that would align for them to get there, but people don't know what they're missing out on until they have that door opened up to them.
Thank you, Hannah. I'm just going to echo what you just said and what Shelley and Edward have been modeling for us. And I really feel that our profession has so much to give to the healthcare workforce. We just have to lead with intentionality. And so finding these opportunities to lead, whether it be through a HRSA grant or other measures and other areas that we are hoping to make good inroads in, it's really needed. I was recently researching a presentation that I was writing about workforce, and although it wasn't U.S. centric, there was a statistic that really blew my mind. That was there's going to be a $10 million healthcare workforce shortage globally. 10 million people shortage, excuse me, not dollar. And I would venture to guess that a lot of those are us, and probably in the most communities that need us the most. And so there's legislative action that needs to be taken, much to what you were saying, Shelley, that there's been some inroads made. And then Edward, you also had mentioned that. We have a lot of work to do. And it's going to take all of us with intentionality to move the PA workforce, but the entire healthcare workforce forward, so that we can all practice and provide the highest quality of care for our patients. So I want to thank both Edward and Shelley and Hannah for leading the way and hopefully inspiring other programs to do the same. And thank you.
Absolutely. Well, thank you all so much. I think this was an excellent discussion. So just a few last minute housekeeping items. So we will go ahead and circulate the slides and a copy of today's recording to everyone who registered. It'll also be available on PAEA's Digital Learning Hub. If you have any questions about PAEA's advocacy efforts, Title VII funding, or questions about PAEA education and federal workforce policy, feel free to contact me at tsmith@paeaonline.org. So with that, thank you all again, and have a good rest of your day.